Let me introduce Jayanth. Jayanth again is my former fellow from SCPGI Lucknow. He has had training in GI surgery and liver transplant at Houston in Texas. MD Anderson, Jayanth?
Dukes in North Carolina.
Dukes. And he's currently at the Apollo in Bangalore. So he will be covering the principles of management of liver trauma. Jayanth, please.
Thank you, sir. So first, congratulations on this wonderful online surgical, and kudos to you for keeping it going, benefiting, I'm sure, countless number of students. So without further delay, let's quickly share my... so skipping the first few initial slides, very well elucidated by the previous two speakers. So quite frequently injured abdominal organ, both in blunt and penetrating abdominal trauma. And majority of these injuries can now be managed non-operatively. We'll go about this in detail in the next few slides. Operative intervention, though, is still needed in approximately about 14% of patients. So the approach to the management, there has been a significant shift from operative to non-operative trauma in the last 3 decades or so, especially for patients who are hemodynamically stable. And this has largely been because of the sensitivity of imaging, mainly the contrast-enhanced CT scan, and advances in both critical care monitoring. And this has led to a significant decline in both morbidity and mortality of these patients. Prior to this, the mortality for patients with liver trauma was in excess of 50%, and majority of them underwent operative management. The management strategy, operative versus non-operative, mainly depends on 3 factors. The most important is the hemodynamic status of the patient. Next is presence of any other intra-abdominal injuries which require operative intervention. And thirdly, the grade of liver injury. Patients with higher grade injuries fail non-operative management as compared to patients with low grade injuries. Now, surgical approach exploration is indicated only in those patients fail non-operative management, that is, who continue to require ongoing blood transfusion and have associated hemodynamic instability or have a persistent SIRS response. The management of higher grade injuries, grade 3 and higher, requires a combined angiographic as well as a surgical approach. Non-operative management is a treatment of choice, like I said, in hemodynamically stable patients with hepatic injury, irrespective of the grade of injury, whether it is the WSES classification or the American Association of Trauma. This encompasses observation and supportive care, and these patients should be admitted to a monitored unit, 6 to 8 hourly hemoglobin monitoring, and adjunctive use of angiography or embolization, depending upon what the contrast CT imaging shows. The success of the non-operative management depends also on the facilities that are available in the local hospital, that is available of the critical care unit, available of a good blood bank support, and immediate OR availability, and also a team which includes surgeons who are, have the expertise in abdominal trauma management, preferably interventional radiologists and interventional gastroenterologists. CT should be performed. Contrast-enhanced CT has already been very well spoken by Dr. Subodh in hemodynamically stable patients or have been stabilized, that is, who have responded to initial fluid resuscitation. And patients who are hemodynamically stable but demonstrate contrast extravasation on CT have higher failure rates, and with non-operative management, and these patients should undergo adjunct measures like angiography and embolization, followed by continued observation. There is no need to rush these patients to the... In patients who are considered transient responders, that is the WSES grade 2 or grade 3, non-operative management should be considered only in selected settings, and angiography and embolization should be considered as a first-line intervention in patients who have an arterial blush on CT scan. Serial clinical examinations, it's very important that we continue to clinically examine these patients by physical exams and laboratory testings to assess if there is a change in the clinical status during the non-operative management. protocol. And it's also important that those patients with associated head injuries or spinal cord injuries should have a slightly different goal of the systolic blood pressure, where instead of the traditional 90 millimeters of mercury for systolic blood pressure, it should be slightly higher so as to maintain a good cerebral perfusion pressure in these patients. And the non-operative management of penetrating trauma, especially gunshot-related trauma, is quite controversial. But selective non-operative management of isolated gunshot wounds, especially the low-velocity gunshot wounds, has become more widely accepted nowadays. The main risk factor in these patients is a missed intra-abdominal injury, like a hollow viscous perforation. So it's important that once these patients are subjected to non-operative management, serial clinical examination, and if there's any concern, cross-sectional imaging should be done. Interval laparoscopy should always be considered in these patients, especially confirm in the absence of other injuries. And in a review of the National Trauma Data Bank, about 40% of patients with isolated gunshot wounds to the liver underwent non-operative management. They were of various grades, and about 55 to 60% were of grade 3 and beyond. And non-operative management was independently associated with fewer complications and lower mortality. The failure rate, though, of these non-operative managements in patients with gunshot-related trauma was about 5%. A retrospective review, and this is basically data to support the use of non-operative management in liver trauma, showed that more than 80% of patients with blunt liver injury can be managed non-operatively with successes of more than 90%. And in a large review of the same data bank, this is over a 10-year period, showed that 91% of the adults could be managed non-operatively. And this the percentage gradually rose with as the time periods progressed. And greater utilization also was because of the use of damage control resuscitation strategies, where these patients could be more successfully managed using the non-operative management protocols. Contraindications are hemodynamic instability after the initial resuscitation, that is, non-responders. Any other indication for abdominal surgery like a hollow viscous perforation or evidence of any peritonitis, especially high-velocity gunshot wounds, and in the presence of extrahepatic injury are contraindications, and absence of the clinical environment that is needed manage these patients using the non-operative is also relative contraindication. Continue to use non-operative. These patients, like I said, if you're considering non-operative management, should be admitted to a monitored unit, should be placed on initial bed rest. Hemodynamically stable patients with low-grade injuries and normal abdominal examination with stable hemoglobin for about 24 hours could potentially be discharged home. The length of observation in these patients is based on clinical criteria alone. Patients with more severe liver injuries require hospitalization, and these patients are at higher risk of venous thromboembolism. Venous thromboembolism, both deep vein thrombosis and associated pulmonary embolism, are the third most commonest causes of death in these patients. So, it is important to initiate mechanical thromboprophylaxis and also initiate the low molecular weight heparin pharmacological thromboprophylaxis in these patients when hemoglobin has been stable over a 24-hour period. And studies have shown that initiation of pharmacological prophylaxis does not increase the non-operative management failure rates or, for that matter, blood transfusion required. Angiography and embolization is an important tool in management of these patients, and it's quite efficacious in hepatic trauma. And it should be used preemptively in patients with extravasation of contrast on CT. And some patients, even though there is contrast extravasation, when you subject them to angiography and embolization, there is no extravasation seen. In these patients, there is a role of empirical embolization, but this needs to be super selective. You cannot go ahead and just embolize the right or left hepatic artery, because this would lead to significant morbidity in these patients in terms of abscess development or necrosis. following the embolization. And angiography and embolization also should be used in patients who have initially failed non-operative management. That is either following rebleeding after surgical management or ongoing bleeding patients, provided they are hemodynamically stable. A systematic review of use of angiography and embolization in patients with severe injuries showed that 1 to 5% of patients treated non-operatively required angiography and embolization for bleeding more than 24 hours after admission. And 12 to 28% of those requiring damage control surgery also benefited from angiography and embolization to control recurrent postoperative bleeding. So it's an important adjunct, and any pseudoaneurysm that is seen should be embolized and taken care of because of the high risk of rebleeding in these patients. And the success rate, like I said, is quite good. What are the complications? Complications mainly are missed intra-abdominal injuries of non-operative, particularly hollow viscous injury, more commonly seen with penetrating trauma than blunt trauma, and transfusion-associated illnesses like transfusion-associated lung injuries, and immunological dysfunction in these patients, especially when you're subjecting them to massive transfusions. And the other risks are associated with the embolization techniques like hepatic necrosis, especially if it is not done in a super selective way, abscess formation, and also bile leaks. Failure of non-operative management is basically defined as a need for operative intervention. That is, patients with ongoing bleeding, ongoing fluid resuscitation, and transfusion requirement with associated hemodynamic instability, and also the development of peritoneal signs. Injury severity score more than 30 to 35, especially, is shown to be associated with failure of non-operative management and associated intra-abdominal injuries. Patients who fail, who become hemodynamically unstable while being non-operatively managed should be immediately taken to the OR for damage control surgery. And in these patients, angiography and embolization should not be considered under these circumstances. And failure of non-operative management is generally low, but once there is failure in these patients, it is associated with increased mortality and more. So in a retrospective review of about 591 patients who have managed non-operatively, 6% failed non-operative management, and about half of these had ongoing bleeding from other injuries. And the higher grade injuries like grade 4 and grade 5 are more likely to fail non-operative. And generally, a transfusion cutoff of about 3 to 4 units of PRBC is an independent risk factor for the need for surgical intervention in these patients. Now coming on to surgical management, this is required in a minority of patients, but about 14% of patients will need surgical intervention. In a surgical management, it's important to do a thorough exploratory laparotomy. One is obviously you're looking at the liver. Is also important to rule out other abdominal injuries in these patients. Damage control principles should be strictly followed, controlling the hemorrhage first and then controlling any associated gastrointestinal contamination. This also allows time for the anesthetist and to catch up on resuscitating the patient. And if the damage control principles are followed and the patient is hemodynamically stable with packing, then subsequently in these patients, resuscitation can be continued in the ICU. Now, coming to the surgical management per se, a midline laparotomy is usually what is favored, but either a right or a left extension decision can be taken depending upon the operative findings. And sometimes the thoraco-abdominal approach extending into the eighth intercostal space might be needed, especially when there is associated hepatic vein or IVC injuries. The initial goal is, after putting in a self-retaining retractor, is to achieve hemostasis. So it is important to push and pack. I'll talk about it a little bit in the next slide. And once the hemoperitoneum is evacuated, it is in situations where it's available, we can consider auto transfusion, but it's important to make sure that there is no associated injuries like a hollow viscous perforation in these patients before considering this. So packing for techniques for liver hemostasis, packing is the most important, and associated things like topical hemostatic agents can be used. So in a damage control surgery, it's very, very important to control bleeding, because if bleeding is not controlled, it leads to a vicious cycle of acidosis, hypothermia, and then a vicious cycle of coagulopathy. So in this, you need to keep calm and remember the 3 Ps: push, pack, and Pringle. Push and pack would be the first, and then obviously Pringle in those cases where push and pack, with push and packing, the bleeding is not being controlled. So in push and packing, it is important to sort of compress the edges of the injured liver parenchyma together, hold it together, and then you place packs. Now, packs, it's important that you place it on all surfaces of the liver, that is between the anterior abdominal wall and the liver surface, the lateral abdominal wall and the liver surface, under surface of the liver, and also between the diaphragm and the liver. It is not a good idea to place packs or gauze pieces between the cut surfaces or the injured liver surfaces, because this is just going to worsen the bleeding. And it is also, you need to take care that you don't overdo it, where you are sort of compressing on the vena cava or the hepatic veins, leading to liver congestion and worsening of bleeding. The adjuncts can be used, topical hemostatic agents. Personally, not a big fan. That we use Surgicel, your Abgels, your flow seals, mainly used for maybe coagulopathic related bleeding, sort of a diffuse ooze, but active bleeding almost never. These agents never help. Electrocautery or argon plasma can also be used to control superficial bleeding. Parenchymal vessel ligation and direct liver ligation. I came across this paper where they use this Carter Thompson needle that we use to close port sites during laparoscopic surgery, where they sort of pass it through and through the liver parenchyma using absorbable sutures, and then bring it on, and then approximate the two sort of edges of the liver, whereby you can achieve control. I personally have not used this. These are the different hemostatic agents that are used, like I said, just as an adjunct, not as a primary modality. Lot has been sort of written and described about hepatography, use of momentum. Again, just packing and getting the two edges together, and these can be used as adjuncts, but not as primary thing. Trying to take a suture, especially in these, invariably it's going to cut through and sort of worsen the bleeding further. Pringle is a very important tool to consider, especially in ongoing bleeding despite packing. Pringle can be done intermittently in 15 to 20 minutes with a gap of about 5 minutes. You can go on for about 60 to 90 minutes, but it's not a good idea to exceed about an hour, especially in patients who are already hemodynamically unstable. If there is no, so Pringle also helps us to tell if there is a bleeding from the hepatic inflow. So there's bleeding is controlled following a Pringle maneuver. It's either because of the portal vein or the hepatic artery. If the bleeding is ongoing, then it's usually because of the hepatic vein or the IVC. Also, you'll need to rule out an aberrant hepatic artery, especially a left hepatic artery, in case there is ongoing bleeding following a Pringle. In severe liver injuries, selective hepatic artery ligation has been sort of described, but again, you need to use it very carefully because the consequences of either ligating the left or the right hepatic artery is quite severe. So it is better to achieve hemodynamic stability using the other measures, and then consider a selective angiography and embolization than to consider hepatic artery ligation. Especially in patients with high velocity wounds, a resectional debridement can be considered, especially if the patient is hemodynamically stable. Anatomic liver resection is best left for a second stage. Not a good idea to consider it during the initial period. And if you have to, I think it's important to involve a hepatobiliary surgeon or a transplant surgeon if you're planning to consider this. Now, coming to the grade 5 injuries, these are extremely challenging injuries because of the inaccessibility. And the mortality of these injuries is quite high. If perihepatic packing should be attempted first to control these injuries. And, if there is a suspicion of these injuries, I think it's important to involve your colleagues in the, a hepatobiliary surgeon or a transplant surgeon or a vascular surgeon. And if perihepatic packing fails control the ongoing injuries, then you need to divert blood away. And these can be done by various ways. So one is a veno-venous bypass. So in a veno-venous bypass, you cannulate the inferior mesenteric vein, divert the mesenteric blood flow. You cannulate your femoral vein to divert the blood from the IVC, and this is again sort of returned to the internal jugular vein via a pump. And at the same time, you are doing a total vascular exclusion. There is a Pringle, and you're also clamping the suprahepatic IVC. Vascular exclusion can also be considered, again, you clamp the Pringle and you achieve a suprahepatic and an infrahepatic IVC control. Again, this needs to be done quickly. You need to mobilize the liver, and it's good to have a colleague who's experienced in doing this. Thirdly, you can also consider an atrial cable shunting procedure. Personally, have no experience, where you pass a catheter with a balloon into the cava. It sort of diverts blood away from the vena cava directly into the atrium. There is also description of this technique. I haven't used this personally. This is sort of a resuscitative endovascular balloons that are placed both in the vena cava and the aorta. So you sort of can place it above the injury in the vena cava and a balloon below. You also have a Pringle on, and then you have a balloon in the aorta. This is a sort of a temporizing measure to achieve control. And so this is a picture where you can see there is a balloon that is placed in the vena cava. There is a rent, and this sort of gives us time to repair the vena cava using a patch. It's important that if it's a large injury, that you don't primarily repair it, because this is going to narrow the cava and cause venous congestion. Being a transplant surgeon, not happy to sort of cover this, but I think it's as a treatment modality, liver transplant in patients with severe liver injuries. There is a European liver transplant registry data where they've sort of done a liver transplant for about 73 of these patients over a large time period. But the overall sort of mortality and the graft loss was quite high in these patients, and they showed that negative, higher injury severity score more than 30 is associated with mortality, and the outcome overall was not good. So only in dire needs, this needs to be sort of considered. Additional considerations, I think it's important about abdominal closure. These patients, most of them go on to develop abdominal compartment syndrome. So it is not, imperative that you do a primary closure in these patients. You can do a temporizing closure, either using a Bogota bag, or like Dr. Gamini described, using whatever that you have available in the local operating theater. It is important to drain these patients, not all patients. And scientific literature has shown that using a closed suction drain leads to lesser infectious complications as compared to a gravity drain in these patients. And also in patients, it's important to consider a post-operative imaging once they are hemodynamically stable, so as to get on top of this. And if there is an possibility of using angiography and embolization in these patients to control further bleeding. Came across these interesting pictures in a recent Annals of Surgery article. These have used towel clips to sort of temporalize them, close the abdomen. You can see the number of towel clips that are there. This patient has a chest drain in situ. And this is another picture where you can see sort of a Bogota bag, but there are two vascular clamps that are still sort of sticking out of the Bogota bag. This is to control pelvic bleeding. And this is an interesting picture. They've used sort of red rubber catheter, and they passed it through a sort of a penetrating liver injury and inflated. Not too sure what this is. Looks like a Sengstaken Blake achieve compression and to prevent bleeding, penetrating injury. Complications of this is higher with severe injuries, and the main things are bile leak, which ranges from anywhere between 1 to 20%. Development of perihepatic or intrahepatic abscesses, especially if you have embolized hepatic artery and hepatic necrosis. So it's important to address these issues following operative management. Also, ERCP is very important with ongoing bleeding. Here you can see right hepatic duct leak, left hepatic duct leak in the second picture. And in the third picture, this is a cholangiogram, but you can see the hepatic vein getting opacified. So this is bilemia, where there is communication of hepatic vein with the bile duct. Role of laparoscopy, all of us are quite skeptical, but there is data to show that there is a role in patients, especially following severe injury, especially in those who are managed non-operatively. And laparoscopic lavage or drainage can be used as a first approach, and especially in a delayed post-traumatic biliary fistula without any other indication for surgical intervention. And also in delayed surgery, to minimize the invasiveness of surgical intervention can be considered. And when you are considering a minor hepatectomy in patients with a devascularized liver, again, there is a mortality, again, is related to the grade of liver injury. Higher the grades, the higher the mortality. But mortality is always high in patients who are requiring surgical intervention, and especially in patients who there is associated vena cava or a hepatic vein injury. There are some clinical scenarios. If time permits, I'll happy to go through it quickly, but due to lack of time, I can skip.
Maybe we will have some discussion, and if time is there, then TD will allow you.
Sure.
So before I hand over to TD, Jayanth, I want to ask you a question from the audience point of view. Suppose I am a general surgeon working in a small setup where I don't have the vascular instruments, and there is a patient who comes to me. Maybe I've got a CT done, and because the patient is hemodynamically unstable, I don't have angiographic embolization, interventional radiology support. I've operated upon the patient. Now, you said that compression and packing is one option, but suppose I see a big rent, either say in the portal vein or in the IVC. I don't have any vascular clamp with me. What instrument would you advise me to put on that vessel so that at least major bleed is controlled, and then I do compression packing and refer the patient to a higher center?
Sir, for a Pringle, one of the good things that can be used is a Foley's catheter. You can sort of cut the outflow of the Foley catheter, put it around the thing, and then you pass the Foley catheter through the hole, and then you can sort of tighten it. That is one of the simple measures we use at during laparoscopic surgery for a Pringle maneuver. The other is if there is a vascular clamp, just to apply a vascular clamp, you can safely sort of use a Pringle for about 30 minutes, or even a red rubber catheter across as a Pringle to achieve.
I was asking that if I can see a rent in, say, the portal vein or IVC,
yes,
I have to put a partial clamp on that, and I don't have a vascular clamp.
Yes.
So what general surgical instrument will be the best to apply on that?
The best surgical instrument will be a bubble clamp. If you have one, will be a non-crushing, non-traumatic to the hepatic vasculature. So that's something that can definitely be considered.
TD, please carry on the discussion.
So thank you, Dr. Jayanth. It's very vast coverage of the. Actually, it's a difficult topic to cover everything on the liver. And before I have noted some points. Before I ask you, I will invite Dr. Sastry, who is watching this thing, to give his comments. Then probably Professor Sitaram. Then I have noted some points. I may ask or I give my comment, and then I open for other questions. Dr. Sastry.
So Dr. Gunatilke, Dr. Shastri is one of the senior most GI surgeons and HPB surgeons of India. Maybe you may have met him somewhere. Dr. Shastri, please.
I think sir is not there.
He's not there. Dr. Sitaram can come in. Dr. Sitaram, please.
Yes, sir.
Thank you very
Good
much.
evening, sir. Yeah.
Good evening, Reddy.
Yes, sir. Good evening, sir.
I enjoyed both the presentations, and I particularly enjoyed Jayanth's statement that hemodynamic instability decides whether you operate or don't. The grade of the injury doesn't decide whether you operate or not. Liver trauma management, very highly labor intensive. You need a lot of people involved in this patient. And I personally have not had the guts to start these patients on low molecular weight heparin once the hemoglobin is stabilized. Never had the guts to do it. So, I mean, I've read about the fact that deep vein thrombosis is a common complication. Never had the guts to start them on heparin. Non-operative management in these patients, many of them develop abdominal compartment syndrome.
Yes.
And that in our experience was quite challenging to manage. Then operating on these patients acutely, some of the things that I learned was that the senior most surgeon available on site should operate. The senior most anesthetist on site should be there, and you should have a senior scrub nurse because they should be there at the beginning of the operation. The beginning of the operation, I've always felt, was the place when maximum trouble happens, because till then there is tamponade. The abdominal wall gives a fair bit of tamponade. And once you open the abdomen, the tamponade goes away and all hell breaks loose. So you need senior people. This is one situation where you shouldn't tell your junior, you open, I will come. No, I don't think that's a good idea. And before you open the abdomen, you must make sure that there are at least 2 suctions which are working well and plenty of mops, because you're going to open the abdomen, you're going to quickly suck out the blood. And if possible, within the first 1 to 2 minutes, you must be able to identify the site of bleeding. And with your fingers, hand, you must control the bleeding and wait for the anesthetist to catch up. And I quite agree this thing about circumferential packing. And also Jayanth mentioned over enthusiastic packing can also devascularize the liver. Formal liver resection in the acute situation, Jayanth has rightly said, not a good idea, because you're operating on a shocked liver. And if you do a formal liver resection of injured liver, then you're very likely to end up with liver insufficiency in the post-op period, because the rest of the liver that's left behind is shocked, and it's not going to sustain the patient in the post-op period. That's all I have. Very enjoyable talks so far. Thank you very much.
Thank you.
So thank you, sir. And there's a few points I have noted, Dr. Jayanth. I was going to
Yes, sir.
re-emphasize what Dr. Sitaram sir has already done. Apart from that, I think to reiterate that we should be a good exposure, large incision, and then compartment-wise, as you said, pack in one area and suck it out, pack in one area and suck it out. Then only one can see from where blood is coming. Otherwise, once you enter, whole abdomen is full of blood. And if you don't compartmentalize, then you are not going to see the bleeding. And by that time, so much blood is lost that it is very difficult to save the patient. But apart from that, in the conservative management, one issue is when the patient has been on the conservative, apart from what you said, the vitals maintenance chart of the the blunt abdomen conservative chart should be filled religiously by the resident, and that includes pulse rate, that includes the blood pressure, that includes that is there any tachycardia increasing, and then abdominal gut monitoring. So these are the 3 things apart from all doing. These are very, very important, and based on, and then at least twice hemoglobin. When we do in PGI, then earlier we used to do twice hemoglobin we used to do to see, because failing conservative management is also very dangerous, and identifying at appropriate time is very critical, that when we have to rush the patient. And always we should ask our resident to blood bank that we might need this amount of blood anytime in the future, and also communicating to the relatives that you are, though this patient is our conservative management, because mostly they are adult, young people. So although we are conservatively minded, but anytime your son or your relative might require exploration, and you should be ready for that, which may be detrimental, which may be life threatening, based on the grading, as rightly you said. And then one point has been left alone, that ABG monitoring is very, very important in these patients. I think this is one of the parameter which is in medical college left, and usually people don't look at the ABG, and that is one of the pointer that you keeps you guiding that the patient is deteriorating or not. Second important point is once your conservative management is successful, and after day 5 or 7, patient develops fever, then once you start thinking about bile leak and going into the create a complication of some local abscess, or there may be abscess because of the infected hematoma. So one should keep an eye on that. Abdominal gut monitoring will also tell about intra-abdominal hypertension, which is also very, very difficult thing. And in a conservative, when in a grade 3 beyond a liver injury and patient is responding to the conservative management, I think this is very important to look at all those things. Usually, you said ongoing bleeding, but usually usually how many unit of Jayanth blood 24 hours required to maintain the vitals, that you say that our conservative management is failing? This is after the in 24 hours. Usually our Jayanth,
3
can
to
you
4
respond?
units, sir. Not
Yeah.
anything more than 3 to 4 units.
Yeah, so that is also very important to give a message that if patient starts requiring this, even if it is not looking like emergency, we should start thinking either re-imaging or going for the surgery. And this is another one this thing. You also talked about auto transfusion.
Yes.
It is important thing, but can you give little bit of, because we have time, can you give some thought about auto transfusion?
Sir, we haven't used it in abdominal trauma. Selectively
Yes.
used it in liver transplant, but the cost of the consumables is so high, and the return that you get is about very minimal. Probably if you lose about a liter, you get less than 1 pint of PRBC, and so I think it's better to be
Yeah,
calm
so
and
yeah, so the thrombotic, yes, sir, Dr. Kapoor, sir, yes.
No, finish this, then I'll ask another question.
So thrombotic complications are very high, and we have to need the ultra filter so that but the blood is once collected, and as you said, usually more commonly used in chest trauma rather than the blood abdominal trauma, because abdomen may be some viscera which is might produce some sort of problem, and this is very, very, very important that we should be very careful. And usually people are not very commonly using this because of the, as you said, cost is very high and the gain is very less. And when patient is in the tertiary care center, usually we have a blood bank which can support the patient rather than rather than auto transfusion, which is obviously something which itself can be detrimental also. Yes, sir, you ask a question.
Two practical questions. One is
Yes.
the dilemma of starting anticoagulation prophylaxis in a patient who is already bleeding. So if at all you want to do it, when do you do it? And second question is, if you are doing a non-operative conservative management of a kind of a major liver injury, what about immobilization? When do you ask the patient to get up from the bed?
Sir, so regarding the thromboprophylaxis, our sort of practice and my personal practice has been that I wait for about 48 hours for the hemoglobin to be stable and the patient to be hemodynamically stable. And especially in lower grade injuries, grade 1 to 3, in about 48 hours, if he's stable and the hemoglobin is stable, I'm quite happy to go ahead and start low molecular weight heparin.
Irrespective of the age of the patient?
Irrespective of the age.
And mobilization?
And, mobilization only for about 24 hours. There is sort of no, scientific literature that's available. There is some data in higher grade injuries, but in low grade injuries, immobilization for anything more than 24 hours is really not.
I was still practicing the 2-week strict bed rest. In fact, just recently we have a patient and we were all, so you say there's no scientific evidence for immobilization for more than...
Not that I am aware, I might be wrong, but I'm...
So one more important point, Dr. Jayanth, that when you are thinking about packing. So it's very important to mobilize liver from all the sides.
Yes.
And it's from all ligaments has to be cut and liver should be lifted. And then it is also found that our sponges, they have a porous area and they absorb the blood, and after a certain time they become ineffective. So it is also important for the generation younger to know that some sort of thing which can cover the liver from all around, and try to just from where the blood cannot be absorbed and swell. Like cotton has a different issue. All these they are the cellulose, so they absorb the water then swell, and then their effect is gone. So then after that their packing is done, then it is more effective. And when you are packing, then probably drain is not required, because it might create the packing may not be effective. So after packing also, it's very important for the people to continuous monitor. Now, same monitoring as one is doing in a conservative patient, and that's why then only all these will be successful. Otherwise, it is very challenging, and it's also medical legal also that you took up a patient and you then don't operate, and suddenly you say that patient has deteriorated. So I think these are the very important points.